Good afternoon. Today we will continue our conversation about the possibilities of surgical treatment of cancer. What is oncological surgery in cancer treatment? What is hidden in this method of treatment, which cancer patients hope for so much? What are the dangers associated with oncological surgery and how to avoid them? What surgeons do not talk about. Today we will discuss the deep processes occurring in the body of a cancer patient during and especially after surgery. We will find out the reasons why some patients live for many years after surgical treatment and touch on the reasons for failures in oncosurgery. At the end of this message and the following ones, I will talk in detail about 12 published methods and directions that reduce the negative effect of surgery on cancer metastasis. This allows me to recommend surgery to many patients diagnosed with cancer. There are enough reports in the specialized literature that surgery accelerates metastasis and is one of the decisive causes of cancer recurrence in cancer patients. The recommendations that will be in this message, and especially in the following ones, will help you reduce the negative impact of surgery, stimulating metastasis of a malignant tumor. A historical view of the problem of cancer treatment allows us to understand the evolution of oncologists' ideas about the most effective methods of treating malignant tumors. Pre-modern surgeons were influenced by the very real possibility of doing more harm than good by operating on patients. From antiquity to the 18th century, the topic of cancer was influenced by the philosophy of Aristotle and the influence of the therapeutic dogma of Galen. Before Halsted, there was a general opinion, the so-called thesis of Celsus. Unless circumstances force it, for example, bleeding or intestinal obstruction, surgical resection should be avoided with a disease at a later stage, in contrast to a tumor at an early stage. The progress of the 20th century in surgery changed this paradigm. If the first 3/4 of the 20th century were marked by aggressive operations, the last quarter of the century has changed this trend. Based on Fisher's teachings on the systemic nature of cancer, oncologists began to reconsider their views on local methods of cancer treatment, such as surgery and radiation therapy. A new crisis has overtaken us now, when there is indisputable evidence that surgery can accelerate the appearance of distant metastases. However, today's surgery remains the most important intervention and gives a chance for life to cancer patients. Why is surgery still a widespread method of treating cancer patients? Surgeons react violently to evidence that surgery stimulates metastasis. This is due to both limited knowledge and the fact that oncosurgery has turned from a science into a commercial activity. Whereas classical oncology is the art of healing and is based not on commerce but on real processes occurring in the depths of the patient's body. Classical oncology is based on the development of measures that can help patients achieve long-term remission, when patients who have undergone comprehensive treatment can live for decades. Today, many reports are published about the adverse effects of surgery on cancer patients. For example, several clinical studies show that surgery is beneficial for some patients, but it can accelerate the development of metastases in others. You will find links to the literature used in the reports in the description under this video. This is important. Why am I talking about the negative effects of surgery in cancer treatment? So that the patient going for surgery is informed, and so that he uses those 12 most important areas of today's oncology, which really reduce the negative impact of surgery on metastasis and allow you to benefit from the operation for health. This approach of classical oncology is fundamentally different from the commercial approach. Go for surgery and you will be happy. Alas, happiness will be, but not for everyone and not always. Not clear? Look at the cancer registries of countries. Informed means armed with knowledge, and therefore you can prevent problems associated with surgery. For this, in this message and in the next one, I will focus on recommendations that allow you to achieve the maximum result from the operation. The life expectancy after surgery depends on these recommendations. Removal of the primary tumor does reduce the number of metastases because it stops the release of new tumor cells. And here surgeons are right when they say that early removal of the tumor reduces the release of tumor cells into the blood and lymph. But not everything is so simple in oncology. Studies have shown that early removal of tumors reduces the release of cells and somehow allows micrometastases that have already developed to grow to a larger size. That is, stimulation of tumor growth by surgery has been discovered and proven. This surgical stimulation of micrometastases was accompanied by a small but consistent decrease in average life expectancy. Oncologists have known for a long time that surgery stimulates tumor growth. But despite this, until recently, surgery was the only method of treating cancer available to civilization. The idea that tumor removal may enhance tumor recurrence and metastasis was first suggested at the turn of the 20th century by Paget and Halsted, who found that patients who underwent resection of cancer did not survive as long as those who were treated expectantly. Initially, such reports were generally dismissed as anecdotal until later evidence demonstrated that surgery may actually create a favorable environment for tumor growth. More recently, reports have emerged that although surgical removal of primary or even metastatic tumors may save or prolong life, surgery itself may trigger or accelerate tumor recurrence. Therefore, several research groups have recently revived the idea that surgery stimulates metastasis and have begun to study the mechanisms by which surgery may have a negative effect. In addition, open biopsy prior to primary tumor resection has been found to increase lung metastasis. Patients often ask about the safety of tumor biopsy, what to do to reduce the risk of stimulating metastasis with biopsy. I will tell in the following messages. In one of the large studies, 2 databases of patients with breast cancer were compared. A large number of observations. The first group is treated breast cancer patients, the second, untreated. And a comparison of the life expectancy of these 2 groups showed that while untreated patients had only one peak in mortality 3 to 4 years after diagnosis, operated patients had an additional distinct peak 7 to 8 years after surgery, which suggests that in addition to important favorable results, surgery can have long-term detrimental effects. It stimulates the formation of metastases in the distant period. Links to studies are in the description of the video. Interesting data were obtained when studying the role of screening. You know that screening allows early diagnosis of cancer. You will learn more about the possibilities of early diagnosis of cancer in my videos on the channel. I will also post links to these messages in the description. 2 groups of women were taken. The first group of premenopausal women, the second in postmenopause. Listen carefully here. There will be important recommendations for both doctors and patients. So, early resection of breast cancer among women whose tumors were detected in screening at early stages in premenopause leads to a higher mortality rate from breast cancer than among premenopausal women from the control group, whose members were not invited to screening. Such a surge in early recurrence and death does not occur among screened postmenopausal women. This negative effect of screening was observed in 7 large randomized trials of mammographic screening for breast cancer, persisted for 6 to 8 years, and led to an increase in early death for every 1,000 mammographically screened premenopausal women. They began to find out why early surgery in premenopause with small tumor sizes sharply increases the risk of metastasis. Computer modeling of the picture of premenopausal recurrence was carried out. It showed that the most likely cause of this surge in early recurrence of breast cancer in premenopause is probably surgical resection of the primary tumor, which almost immediately follows its detection. It is believed that the physiological process responsible for early premenopausal recurrence is the interruption of breast cancer dormancy by surgery. Stimulation of metastasis by surgery is associated with the angiogenic effect of interruption of tumor dormancy and the subsequent growth of breast cancer metastases. Recommendations: how to prevent stimulation of metastasis by surgery in patients with early breast cancer and premenopause. Not everything is so fatal for premenopausal women. A study of menstrual and estrous cycles shows that the disruption of tumor dormancy may depend on when in the menstrual cycle surgical resection of the primary premenopausal breast cancer is performed. It has been reported that women who undergo resection in the follicular phase of the cycle suffer from more frequent and earlier recurrence of metastases compared to those who undergo resection in the luteal phase of the cycle. These data indicate that the reproductive hormone environment and host condition at the time of resection may be a critical factor in determining whether the operation will cure the woman or whether she will develop widespread lethal metastases. In this way, the body may reduce the risk of the negative impact of the operation on metastasis. This is very important. What happens in the tumor and in the tumor-bearing organism during surgery? Gunduz et al. Reported that after the removal of one of the tumors, changes in the proliferation kinetics of the residual focus were observed for 24 hours. Cell division increases. These results completely refute the idea that the removal of the primary tumor is a local phenomenon without other biological consequences. That is, the conclusion, "Let's remove it faster and everything will be fine," is far from true. Therefore, tumor dormancy was called an important factor, and its violation is associated with metastasis. Thus, removal of the primary tumor leads to the creation and rapid growth of a large number of hidden metastases, most of which would be dormant or would die if the primary tumor were not removed. Thus, it was proven that the growth-stimulating effect of surgery on metastases in the postoperative period is due to the removal of the primary tumor. Studies by Simpson-Heron and others in lung carcinoma revealed the effect of surgery on the host tumor system. Early surgical removal of the primary tumor provided some long-term cure and increased survival compared with untreated controls. However, late removal was incurable and resulted in increased proliferation and growth rate of lung metastases. Hence the recommendation that tumor staging is very important, since the timing of surgery and its relationship to tumor spread is critical for the stimulation of metastasis by surgery. In this study, surgical stimulation of pulmonary nodules was associated with a small but consistent decrease in median survival. The ability of the primary tumor to slow the growth of metastatic foci is known as concomitant tumor resistance, and this topic was comprehensively reviewed by Ruggiero. The concept of concomitant tumor resistance was introduced, a phenomenon in which the host bearing the tumor is resistant to the growth of secondary tumors. When the primary tumor suppresses the growth of metastases, as a result of the release of biologically active substances by the tumor, micrometastases remain small and dormant. After the primary tumor is removed, inhibitor levels fall and previously dormant metastases spread with renewed vigor. Thus, tumor removal may turn on the angiogenic switch and stimulate metastasis growth. In addition, it has been proven that surgical trauma to normal tissue promotes implantation and/or growth of circulating tumor cells, and that the degree of trauma affects the success rate of metastasis in these circulating tumor cells. That is why reducing the volume of surgery, sparing operations, leads to better treatment outcomes. It has also been confirmed that the ability of malignant tissue to respond to surgical injury to normal tissue does not depend on the type of tumor cells or even the species, and that the effect of the tumor response to surgery is temporary, decreasing as the wounds heal. This is very important because it emphasizes the importance of the postoperative period for metastasis. We will talk about this in more detail in the following messages, in which we will discuss ways to reduce the stimulation of cancer metastasis by surgery. Today, a new direction has appeared in commercial oncology, reconstructive plastic surgery, which increases tissue trauma, and therefore increases the risk of metastasis. In pursuit of beauty and life, it is better to choose life This is my recommendation. Why do some oncologists, mostly of the old classical school, tell the truth about the negative role of surgery in cancer? Because after the surgery, circulating tumor cells were found in the blood in % of cases, decades later. Recently, Meng provided strong direct evidence of tumor dormancy in breast cancer. They studied the frequency of circulating tumor cells in patients with no signs of recurrence or metastasis 7 to 22 years after mastectomy. The patients had no signs of clinical disease and considered themselves healthy. Absolutely healthy women 20 years after surgery. In 60% of them, cancer cells were found in the blood. This figure is much higher and is due to the difficulty of detecting circulating cancer cells. This fact, and not hope, should be paid attention to in a group of patients who live a long time after surgery. Therefore, we should not talk about a cure, but about remission. What should be done to prevent circulating cancer cells from forming metastases? We will often talk about in the following videos. Circulating cancer cells remain in almost all patients after surgery for decades. But what is important, after removal of the primary tumor, the half-life of circulating tumor cells is several hours. That is, circulating tumor cells quickly die. Where do circulating cancer cells come from then? Scientists have come to the conclusion that several years after removal of the primary tumor, clinically silent tumor foci may exist that continuously secrete circulating tumor cells. This is relevant for both the follow-up observation of patients after treatment and for planning modern methods of treating the patient in the late periods after surgery and the feasibility of diagnostic methods. In addition, cancer has a pronounced tendency to heterogeneity and unpredictability. The unpredictable and sudden appearance of metastatic disease can occur years, and often decades, after the primary cancer. In particular, Hadfield published a lecture with the notable title, The Dormant Cancer Cell, where he used the word dormant to describe malignant cells that, although they remain alive in the tissues for a relatively long time, show no signs of multiplying during this time, but retain all their former and vigorous capacity for multiplication. Why is it important for patients to know the dangers associated with cancer surgery? Why can't we hide the possibility of a negative effect of surgery on the metastasis process? This is especially true for patients who live for decades after surgery and consider themselves healthy people. Because today there are methods of treating a cancer patient that prevent the stimulation of metastasis by surgery. And this is not only chemotherapy and hormone therapy. In achieving long-term remission in a cancer patient, heredity and the state of the immune system are also important. We will talk about these areas in detail in the next video, in which we will discuss the way to suppress residual tumor foci after surgery. The process of cancer prevention and prevention of cancer metastases is complex and multi-stage. It should begin at the birth of a person. Cancer prevention is based on the stability of the genome. Today, ways to prevent genetic mutations have been developed. My channel, Current Issues of Modern Oncology, is more focused on the prevention of cancer metastases. For the prevention of cancer and the treatment of concomitant diseases, I opened a second channel. It should become a school of health. I will also leave a link for subscribers to the second channel in the description. On the second channel, we will touch on the prevention and treatment of many diseases that lead a person to genome changes and cancer. Take care of yourself. Until next time.